It's interesting. You might think that dermatology, being a primarily visual field, is well matched for telehealth. I think a lot of the things that we were trying to work through before COVID, before the pandemic, things such as malpractice coverage, things such as how to make sure you get high fidelity, good quality images, that's kind of just gone by the wayside in a sort of just let's try it and see what happens sort of approach, because we really have no choice otherwise.
This is Dermatology Weekly from MD Edge, where we bring you conversations with clinical and research leaders in the field of dermatology with the latest dermatology news. New episodes drop on Thursdays. I'm the voice of MD Edge Podcasts, Nick Andrews. Welcome aboard for episode 63 of Derm Weekly. We have a very practical episode for you this week. Coming up later, Dr. Candrice Heath is here to discuss telemedicine and how to maximize your experience for yourself and your patients. That's coming up after the news. In the news today, we'll be focusing on the Kawasaki disease presentation for patients with COVID-19, as well as a call to action from dermatologists for characterizing and managing skin complications associated with COVID-19. Before we get to the news, a quick reminder that you can reach the show by emailing us at podcasts@mdedge.com, or you can find us on Twitter at mdedgederm. We'd like to mention our listeners in Austria and California and thank them for joining us wherever you get your podcasts, and mention that we are indeed considering AI-related topics in the near future per listener request. Okay, it's time now for the latest news in dermatology for the week of May 11th. We begin episode 63 with the symptom of Kawasaki disease in children, possibly linked to COVID-19. A novel inflammatory syndrome in children involving symptoms that are seen with atypical Kawasaki disease and with toxic shock syndrome that may be linked to COVID-19 infection. This is according to data from the National Health Service England, The Lancet, and the New York City Health Department. Dr. Dimitra Deskalaskas reported on May 4th that in the period between April 17th and May 1st, 15 children in New York City hospitals have presented with the condition that is being referred to as Pediatric Multisystem Inflammatory Syndrome. The following day, May 5th, the New York State Department of Health released a health advisory that 64 suspected cases had been reported in children in New York State hospitals. There was also a statement from the UK's Pediatric Intensive Care Society on April 27th, in which officials said that blood parameters consistent with severe COVID-19 in children, as well as abdominal pain, gastrointestinal symptoms, and cardiac inflammation. Initial reports of the first 15 cases showed that patients all had subjective or measured fever. More than half of the patients reported having a rash, abdominal pain, vomiting, or diarrhea. However, fewer than half of the patients had respiratory symptoms. In a case study published in Hospital Pediatrics, Dr. Vina Jones reported that a 6-month-old infant was admitted and diagnosed with classic Kawasaki disease and tested positive for COVID-19. The patient also had fever and mild respiratory symptoms. Dr. Jones is a pediatric hospitalist in the Bay Area. As of the publication of this podcast, more cases had been reported from the UK in the Lancet. In London, 8 children with hyperinflammatory shock, they showed symptoms similar to those seen in patients with atypical Kawasaki disease shock syndrome, or toxic shock syndrome, presented within 10 days to a pediatric ICU in London. Clinically speaking, these patients were similar to those seen in New York. They had presented fever, rash, conjunctivitis, peripheral edema, extremity pain, and gastrointestinal symptoms. All of the patients developed warm vasoplegic shock and did not respond to volume resuscitation. 7 of the British children needed mechanical ventilation for cardiovascular stabilization, although most of them had no significant respiratory involvement. Dr. Don Nault is assistant professor of pediatrics and ID at Oregon Health and Science University's Dornbecker Children's Hospital in Portland, Oregon. Dr. Nault pointed out that causality has not been established between this novel coronavirus and the inflammatory symptoms akin to Kawasaki disease. She spoke to MD Edge reporter Tara Haley to shed some light on the case study from California and the data coming from London and NYC. Dr. Nault told Tara that if there is indeed a relationship between COVID-19 and these inflammatory symptoms, the leading hypothesis is that the novel virus is stimulating the immune system so as to promote vasculitis. Dr. Nault went on to say that the relationship between the coronavirus and these inflammatory symptoms may have resulted from genetic differences within the host, or from changes in the virus itself, or from something that we just don't know yet. Dr. Audrey John is chief of the Division of Pediatric Infectious Diseases at CHOP, which is the Children's Hospital of Philadelphia. Philly clinicians have seen several cases that are similar to the cases described by NHS England and the New York City Department of Health. Dr. John said that most children appear to have antibodies to the novel coronavirus even when they don't have any virus detectable in their nose. And she added that this suggests that these inflammatory symptoms are post-infectious and are likely due to an abnormal immune response following viral infection. As we published this podcast on May 14, 2020, there are fewer than 100 reported cases like this among pediatric patients in the U.S. Dr. John says that physicians should be advising families to bring their children and teens back to the clinic for evaluation if they develop a new fever, rash, or abdominal pain and diarrhea. Families should not be afraid to seek care when their children are sick, she said. Kawasaki disease is rare. It requires a fever of between 101 and 104 or higher degrees Fahrenheit for at least 5 consecutive days, along with 4 of the 5 following symptoms. 1. Rash over the torso. 2. Redness or swelling on palms or soles of the feet with peeling coming later. 3. Bloodshot and or light-sensitive eyes. 4. Swollen lymph glands in the neck. And 5. Irritation and inflammation of the mouth, lips, and throat, including possible strawberry tongue. Kawasaki disease's etiology is unknown, but some evidence does suggest that it has an infectious trigger with a winter to spring seasonality. The authors of the case study note that past research has linked Kawasaki disease with previous or concurrent infections of rhinovirus enterovirus, parainfluenza, respiratory syncytial virus, influenza adenovirus, and the 4 common human coronavirus strains. If you'd like to read the case studies or any of the relevant research cited here, please click the article link in the show notes. The links to the literature are embedded throughout the story article. And we now move to 2 different COVID-19 case reports that have prompted a call to action for dermatologists to participate in research. The 2 reports were published simultaneously in JAMA Dermatology along with an accompanying editorial which called on dermatologists to help with characterization and management of skin complications that have been associated with COVID-19. Dr. Lauren Madigan is with the Department of Dermatology at the University of Utah in Salt Lake. In the JAMA editorial, she and her colleagues urged the field to lead the efforts. The 2 case reports published in JAMA suggest that, thus far, patterns of skin symptoms have been heterogeneous. 20% of patients with COVID-19 have experienced some version of these symptoms. One case reports that just 1 day after an elderly patient was admitted for acute respiratory distress, she developed a papulosquamous and erythematous periumbilical patch. The respiratory distress rapidly evolved into a digitate papulosquamous eruption that involved the upper shoulder and back. It was described as clinically reminiscent of pityriasis rosea in a case report, which came from the divisions of dermatology and venereology, pathology, intensive care, and virology lab at Hôpital Cochin in Paris. In the other case report, pruritic erythematous macules, papules, and petechia affecting the buttocks, popliteal, fascia, anterior thighs, and lower abdomen all appeared 3 days after the onset of fever in a 48-year-old patient in Madrid. A biopsy demonstrated a superficial perivascular lymphocytic infiltrate with red cell extravasation and focal papillary edema, along with focal perikeratosis and isolated discokeratotic cells. This case was reported by researchers in the Department of Dermatology at Ramón y Cajal University in Madrid. The authors of the editorial point out that the limited information available from cases of cutaneous eruptions that are associated with COVID-19 is reason enough to get involved. Dr. Candrice Heath is professor of dermatology at UC San Francisco. She said to participate, dermatologists do not need to be affiliated with an academic institution. She directs those interested to submit their case reports to a registry that has been established and set up by the American Academy of Dermatology. You can find a link to that registry, along with the article and commentary and perspective from New York University dermatologist Dr. Kirsten Lasoko in the podcast notes. Dermatology Weekly. We'll be right back with Peer to Peer. Welcome back to Dermatology Weekly. It's time now for Peer to Peer, with Dr. Candrice Heath.
Today, I am talking to Dr. George Hahn about telehealth and the impact on how we practice dermatology. Things have definitely changed. Dr. Hahn is from the Icahn School of Medicine in New York, New York. Thank you so much for joining me today, Dr. Hahn.
Thank you. Thank you for having me.
So let's just jump right in. How do you really think dermatology is handling this change in practice towards telehealth?
I think we've, as a specialty, been doing a great job. So it's interesting. You might think that dermatology, being a primarily visual field, is well matched for telehealth. I think a lot of the things that we were trying to work through before COVID, before the pandemic, things such as malpractice coverage, things such as how to make sure you get high fidelity, good quality images, that's kind of just gone by the wayside in a sort of just let's try it and see what happens sort of approach, because we really have no choice otherwise. People are at home, they don't want to come out, they're not able to come out in a lot of cases. There are a number of guidances out there saying that the patient shouldn't be coming into the hospitals, for example, unless it's an urgent matter. So we've had to find a way to provide this care to patients. And I think even though, and I think we'll get to this in a little bit, even though there are HIPAA relaxations, so some of the issues that you might have dealt with before this, like getting a HIPAA secure video platform, you don't need to worry about. A lot of privacy and security issues are still out there. There's all this issues about Zoom and the meetings being able to be guessed by other people. So there are still things to keep in mind, and we have to do the best for our patients. And I think as a field, we're starting to learn and kind of it's jump-started the development and maturation of teledermatology to a large degree, such that I think we're going to see a lot more progress going forward in terms of our ability to conduct good quality teledermatology visits with patients.
Yeah, I certainly agree with that. I think that this definitely has catapulted telehealth for dermatology and really for medicine in general to definitely a new level. Telehealth has allowed our patients to still have access to us during this pandemic. What types of skin issues are you seeing in your patients that can be managed via telehealth visits?
Oh, that's a great question. Actually, from a practical standpoint, we're seeing almost everything. And some of that is by design and some of that just happens. No matter how much you try to design a system, you try to tell patients, well, we're not really that good at examining concerning lesions over telehealth necessarily. There are certain things that you have to come in for. People are still worried about the new skin growth and they're still worried to come out. So you put those two things together and you're going to end up seeing some patients in your practice with concerning lesions that you can't really make out on a choppy video signal, and you're kind of stuck trying to figure out what you can do. We've come up with a number of solutions. First and foremost, we do tell people and kind of give them reassurance with a lot of the lesions that we're thinking about and talking about. You're able to get some history from it. You're able to give some guidance as to whether or not it may be safe to wait a little bit of time before they come in. And another thing that I've been doing recently is there's this genomic test for melanomas. I don't know if you heard about it. I hadn't used it very much before the COVID pandemic because, we could biopsy patients in the office and certainly there was the advantage of being non-invasive. But now that the whole paradigm has changed, I've actually used it more than I ever did before, because invariably what happens is a patient comes in, and I'll tell you a real story of a patient coming in who his physical therapist pointed out a spot on his back. He was outside on a balcony trying to show me. He had his friend touch it to see if it was raised because he couldn't even reach it. So in the end, I just told him, look, we're going to send you this kit. It's pretty straightforward. You probably need somebody to help you do it, but you just send it back. And we have a pretty high confidence that if you get a negative result, it's going to be a negative test. So I think that's something, just one example of a resource that we might not have thought about before this, but now is turning out to be pretty useful. So I think that's one nice point. I think practically speaking, we're seeing everybody right now, psoriasis, acne. Acne would be pretty easy to triage via telemedicine. So those are nice. Obviously, eczema are bread and butter diagnoses. We're going to have to do a lot more experimentation. Certainly if there's a lesion that's scaly and erythematous. We're not able to tell with great certainty if it's tinea eczematous, if it's erythema annulare. So, there's some experimentation involved, but I think as long as you're upfront with the patients, they understand it too. And, you mentioned the explosion of telemedicine, and it really has been nothing short of that. Last year, all year, I think overall in the health system, we probably had about 2,000 to 3,000 telehealth visits. And this year, in March alone, when this thing was ramping up, by the end of March, I think the numbers I saw was like around 30,000. So it's just
Wow.
absolutely just kind of been a huge change in the way we practice medicine.
So we talked about some of the things that you're actually seeing patients for via telehealth, but what are those things that you still think warrant an in-person visit?
For in-person visits, I mean, certainly it's very hard to recapitulate a total body skin exam over telemedicine. There are ways to do it. Certainly, usually it involves another person helping, but even then, it really leaves too much to be desired, I think. And I think those are really better off being seen in person. We actually are upfront with patients, telling them that it's very hard to determine lesions that you're concerned about in terms of precancer, that kind of thing, or cancerous growths. But people still schedule the appointments and want to see you. So we have to find some way to help them as best we can. And that's where, things like getting a more thorough history, talking to them more about it, symptoms, things like that can be very helpful. So I think those are the main categories that I'm a little less comfortable triaging. But I can tell you, we have patients who we've never met in person who we've started biologics on for psoriasis or atopic dermatitis. So I think with regards to most of the other things that we think about, if you really break it down and think about it, absent those diagnoses where you really just are unsure of what's going on, if it's a pretty clear case of psoriasis, I would say that your treatment options are not limited by the fact that we're handling over telemedicine. And I think that's really nice for our patients. There's a number of treatments out there that you don't need laboratory screening for, so those are helpful to have on hand. So I think most of what we can do in person, we can accomplish, with the caveat that the total body skin exams, and especially pigmented lesions, I'm a little less comfortable triaging over telehealth.
I think that's a great summary, and thank you for sharing your opinion on that. So, what about those patients? And I don't know if you've run into this yet, but they don't really have access to technology to even have a telehealth visit. What do you think we should do about those patients?
That's a big concern, and I think it's reassuring to know that the CMS has to some degree acknowledge that. And I think it was actually, I want to say over a month or two ago, there's a press conference on the White House lawn, and they mentioned this. We're concerned about our seniors out there who were making all these waivers and all these accommodations for telehealth because we think that is the best emulation of an in-person visit. But what about those patients who don't have access to a smartphone, who don't have access to a computer with a webcam or a laptop or a tablet or something like that, or just can't figure it out? I mean, I can tell you, we're on the Epic system at Mount Sinai, and there's a pretty significant barrier to entry, which is whole registration process, the download process, the check-in process. It's a lot of steps that you have to take to even start a telehealth visit. And that's assuming you even have the right equipment there. So what's really nice and very positive recently is that on April 30th, 2020, there was a new guidance out from CMS that stated that they would pay for telephone visits. Those visits will now be paid at the level of an established visit, levels 2 through 4. So they'll map out to those payments for established levels 2 through 4. And so that really has pretty much tripled the reimbursements of those previous visits in some cases. And it makes it a lot more impactful, which is not to say that people weren't doing the telephone visits before, but now, I think the recognition is there that we're still doing important work for our patients, and you don't necessarily need that video signal to be able to do this. And we certainly don't want to create any artificial barriers to access to care, which I think is the most important part of this. So I think now we're pretty comfortable saying, if there's really a huge issue, you can just go ahead and do a telephone call. and you bill it as a telephone call, but you'll still get reimbursed at a reasonable amount, which is really nice and reassuring. It's nice to see that there's the recognition of the value that we're providing in terms of medical care. So that's one way. The other thing that I would say is that if, depending on what platform you're using, we have a backup platform in case there's any technical issues. Sometimes you'll be in the middle of a call and you'll have seen what you have to see, but maybe the audio is glitchy. So in those cases, I've actually told the patient, I'm going to hang up and I'm going to actually just call you and we'll just finish out the consultation over the phone, and that's usually fine. So there's things you can do to try to rescue a call in the middle of it if you need to.
I think during the pandemic, focusing on anything that's positive, I really like to hold on to that. So just thinking about our seniors across the nation who now, post-pandemic, will be able to be more tech savvy than they have ever been. And that is definitely something that is exciting for the future.
Yeah, for sure. I've had, 80 plus, 90 plus year olds on telehealth visits, and it's quite something. They know how to figure it out.
They do. So currently, you are the chief of Teledermatology for the Department of Dermatology at Icahn School of Medicine in New York City. How do you personally envision using telehealth as we move into the planning stages of our post-COVID life?
Thank you for asking that. I think that's a very, very critically important question. I think there's no doubt that we at Mount Sinai see telehealth as a big part of our future going forward. There's a number of reasons for that. If you look at the utilization of telehealth services prior to COVID, it really wasn't that great. There have been numbers published, but in no case I've seen anything approaching 10%. So they've all been pretty low amounts of patient utilization of telehealth services at all. And I think there's a couple of barriers there. Number one, a lot of practices were not offering it because they just perhaps didn't see the need to. Number two, patients didn't think of that as top of mind as a legitimate option. And I think that's for sure changing now. So with those two things together, now a lot of practices have had to engage in telehealth. A lot of patients are using it now and they're seeing the benefits that it can provide. So I think there's no question in my mind that that's going to be something that the marketplace demands going forward. I think there's going to be no way around it to some extent. So I think it's important that as we go ahead in the next phase, we kind of plan out how we're going to approach this. We use the lessons we've learned during this pandemic of just large numbers of people utilizing teledermatology services to help map out what makes sense for our specialty going forward and how to utilize teledermatology, as well as technical requirements that we should be asking of our vendors providing these services. A couple of things that I would stress. Number one, I think there's two concepts here that it's important to differentiate between why patients are engaging in teledermatology. And on one hand, you can think of it as a convenience factor, right? And I think before COVID, that was probably the primary reason people engaged in telehealth. They didn't want to come into the office, or it was at an off time that they couldn't find a provider. So you've seen those ads out there, I'm sure, where it says you can talk to your doctor even at 2 a.m. Through these services. So there was a convenience factor there that was nice to have. And certainly I've been doing telemedicine for several years now. And a lot of my patients who I was seeing before this, and it was a relatively small number, were doing it for more of a convenience factor because they didn't have to come in all the way to the office. They didn't have to travel, take half a day work off. And that's certainly nice to have. But I think the bigger thing that we can address going forward with telemedicine is access, right? So that's a little bit of a separate issue from the convenience factor, because this captures why we're doing teledermatology now during COVID, right? Because otherwise, these patients would have no access to services at all. The practices are either closed or there's guidance in place from the hospital, from the city, from the state, et cetera, that they're not supposed to be coming in for non-urgent issues. So given that they otherwise would have no access to our services, the only way they can engage a specialist to really triage and treat their concern is through telehealth. And I would extend our thinking about the access problem to not just the parameters of a pandemic causing people to have to stay at home. I would extend that thinking areas of the country where there's no dermatologists. And there certainly are a lot of areas like that. Access to dermatologic care has been a big problem in the past. And we're at a point where the specialty, we have the skills needed to address this. We have patients in need of this care, and we have technology that doesn't seem to be a bottleneck. It doesn't seem to get in the way. It's not ideal in some cases, but it's good enough to provide pretty good quality of care, I think, and a good standard of care. And so I would hope that people going forward can think about telemedicine in this way, in developing perhaps new projects to bring care to patients in rural areas who otherwise would either not have a dermatologist or would have to wait a very long time. And that's what we've been doing for a couple of years now with a program we have upstate, and patients that we manage hundreds of miles away because otherwise they'd have no easy access to care. And we've been getting very good results from that. So I'm hopeful that we can use telemedicine in the future as a way to buoy up our access to the specialty. And of course, it'll be nice for some patients. They'll have the convenience of not being able, not having to come in. One of the things I tell a lot of practitioners who are a little bit still on the fence about going forward and continuing to offer these services is if you think about those patients who you want to maybe get a more frequent follow-up, but you don't have to necessarily get the best exam, and mostly on the follow-up, you're doing a lot of counseling, or you want to do a check-in before titrating doses of a medicine, for example. Those are situations where you actually might improve your show rate by offering telemedicine services. So that patient who, normally would say, hey, I'm doing good, or my rash has pretty much gone away, I'm not going to go ahead and take time off of work to go to the office. All of a sudden that dynamic changes for them. And it's like, well, let me use my break to talk to my dermatologist and just check in. Even though things are doing much better, I value the opportunity to be able to speak to them and get a little counseling without having to make too much of a time investment. So that's one thing I tell people, that you actually might improve certain metrics of your practice and be able to help it out in that way. Another thing that we've told people, another use case, and you can think of many, is for cosmetic routine follow-ups. A lot of times you have the patient come in, you take a look at them, make sure everything's going well, and you actually don't do anything. Perhaps they don't need a touch-up because you did such a good job the first time. If you convert those patients to telemedicine visits, it's short, it's sweet, to the point, patients are happy, and you actually save a slot for somebody else that you could see in person that day. So there's a lot of potential use cases that make sense, not only from the patient perspective, but also from the dermatologist perspective, that can help your practice run more smoothly, for example. So, I'm hopeful that we really tease those out and find a good place for telemedicine going forward.
Dr. Hahn, all of those examples that you gave were wonderful examples, not only from the access point of view, but then also thinking about patients that we all currently have and how we can now change our thinking to say, wow, maybe we can definitely not only focus on convenience, but look at this telemedicine platform as a way to increase access to our practice overall. I think those are all great points that you made. So now, when you speak to a dermatologist, and I'm sure that you've had many people contacting you, if you speak with a dermatologist who is sounding pretty weary about using telemedicine, what are some of the top things that you tell that dermatologist in that moment?
A lot of the issues that people were thinking about beforehand are now gone. The question is, when things get back to normal, which they will, how are we going to go forward? I think if you think about the way that telemedicine can help your practice and the patient preference for it, because I think we're going to see more on that, it's going to be hard to justify not offering some sort of services to your patients who are requesting it, because they might go to somewhere else, right? So a couple of tips to make sure that your practice is successful is the number one thing I will say that, I've been telling people, but that to echo back, is that you need higher quality photos. So what I mean is to say that when you're doing a telemedicine visit over the video, and I'm sure we've all dealt with this, there are just too many variables. There's the compression of the video, there's the signal both for the patient and for you. Depending on the platform you use, they might be using the cloud, they might be using servers located in a certain place. So all that data has to go somewhere, and with more people using video conferencing and things nowadays, the video signals have just been worse overall. So it's very hard to make out things well. And if you've done a lot of telehealth visits, you know it's frustrating to sit there and tell the patient to tilt the camera a certain way, to move it out, to move it in, to try to get it in focus. It's much better if you're able to get photos beforehand. I think there are a couple of platforms out there that enable you to have a HIPAA-secured kind of chat with your patients beforehand. And what that allows you to do is it allows your office staff to onboard the patient, which means they can give you a brief history/chief complaint. Your office staff can get allergies and other issues out of the way even before you see the patient. And the patient can send in some representative photos. I think how this helps is a couple of factors. Number one, they're more likely to be using the back-facing camera on their smart device, which usually has a better resolution. They're able to actually visualize the images that they're taking and see if they think it's representative. With the caveat that even before this, I'm sure you've had patients bring in their phones to your practices to try to show you images. And I would say in probably the majority of those cases, they're blurry photos. So you can't really assume anything, but at least you can try. There are some guidelines out there to give tips for your patients to take better photos. One of the sites we've been pointing people to is Visual DX. They actually have a telemedicine platform. But as part of that, they have a one-page tip sheet that's pretty useful. So sometimes we have people look at that. And then they send in the photos, and then you review them. And it actually makes your visit much more efficient because you can get more to the point. You're not wasting time having them kind of position the camera a certain way because you already know what you're looking at and looking for. And so then you're counseling them. Maybe you're getting a few more details from them, but it's much more helpful that way. So to have the photos beforehand. If you don't have access to a platform that gives you that secure chat, you can have them email it in. It's not clear to me whether the HIPAA relaxations are really going to cover the photos, but I think it's hard to envision people getting into trouble. So we always recommend that you get a HIPAA secured email server account if you can, if you're asking for patients to send in photos. Because what happens is that once they send those photos to you, you are responsible for the safety and security of that photo. In a pinch, if you're just having them email you, the recommendation would be to immediately delete those photos after you reviewed them so that you don't run into issues with the email getting hacked and photos going out. So that's another point that I would certainly make, but the photos are very helpful. The second thing I would say is that I think it's important to set expectations, both for yourself and for the patient, because if you're not comfortable seeing concerning lesions, suspicious moles, those things, you should make it very clear to your schedulers that patients should be told that if it is one of those problems, they cannot be seen by this methodology. So it's important to set the expectations up front, I think, and to be realistic as to what you think is reasonable. You know, when I started doing telemedicine, I actually handpicked the patients that were coming to me for follow-ups. And so I would pick the patients, for example, for phototherapy follow-ups, where usually it's just counseling and making sure they're doing okay. But regulatory-wise, we would have to have a visit every certain number of phototherapy visits. So rather than having them come in a separate time to do that, we could do it via telemedicine. For acne follow-ups, it's pretty helpful, especially for male patients who are on isotretinoin. A lot of times it's just a counseling visit, if anything. So you can switch those over to telemedicine pretty easily. So, you know, if you're on the fence, start with the easy things, start with the lowest hanging fruit, and then go from there. The last thing I'll mention is to have a backup plan technology-wise, because there's always going to be issues. So if your backup plan is just to call them, great. If your backup plan during the pandemic is to FaceTime them, that's fine as well. We've recently been using the Doximity app. So Doximity being something that all physicians have access to registering. They have a free application and they have a free video conferencing methodology. I think what separates this from everything else is that in the case of, like, let's say a visit that's not, so we use the Epic, as I mentioned earlier. If we can't complete that visit, I can actually click through Epic on the phone number. It'll go to the dialer. I can click video call. It sends 2 text messages to the patient. They have to click allowing them to get messages, and then they have to click to join the call. And without having to download any applications at all, they're right away in a video visit. So the whole process takes less than a minute. So from you sending that request to them to you being able to start the visit is less than a minute. So that's what I look for in a backup option, something that's very quick and easy that doesn't require further downloads or anything. And just to kind of be clear, I have no conflicts of interest. I have no relationships with any of these companies. I'm just trying to be helpful and provide some options for people.
Well, thank you so much for those tips. This has been wonderful. Thank you so much for all of your answers, and I'm sure that all of our listeners are going to really enjoy learning more about telemedicine.
All right, thank you. And I would suggest that if you have any more questions, anything you need, the AAD website, the Telemedicine Hub, the Teledermatology Hub, has a lot of resources. It has a list of free applications that you can use. If it's not on there already, we've generated some sample workflows for you to work from. So there's a lot of great content there, so definitely look for that.
And that concludes episode 63 of Dermatology Weekly. Derm Weekly is produced by MD Edge editors Elizabeth Meshkati and Melissa Sears. The peer-to-peer portion of the show is produced by Melissa Sears and is hosted this episode by Dr. Candrice Heath. The guest this episode was Dr. George Hahn. The news portion of Derm Weekly is produced by Elizabeth Meshkati. The episode's news was based on stories originally published at MD Edge by Tara Haley and Ted Bosworth. All MD Edge podcasts are produced by MD Edge and Medscape Editor-in-Chief Dr. Ivan Oransky, and executive editors Kathy Skarbeck and Mary Ellen Schneider, as well as multimedia editor Terry Rudd. Derm Weekly is produced, edited, and engineered by Tyler Mundank. For all of us here at MD Edge, I'm Nick Andrews. You're listening to Dermatology Weekly.